That introduction, let me pass on to, of course, I'm not going to do all this. I just want to tell you that, this is what I think we, okay. Hey, stop it, man. Okay, right. Okay, let us go to post-operative care. So how do you deal with a patient after surgery? You've done a beautiful FESS, okay, no patient factor, like no Samter's triad and things like that. So for following up a patient, we should know the stages of healing. This I learned from Professor Vigand. If you see his time-lapse video, he's got a fantastic time-lapse video. If you have time, you can get it from me. I have that with me. So he has described 5 stages of healing post-operatively. Stage 1 is the stage of edema. You can see that this is, I think, the stage of edema and crust formation. Stage 2 is soft exudates. There is formation of soft exudates. Stage 3 is formation of hard exudates and synechiae. Stage 4 is consolidation. Stage 5 is stabilization. So I asked Professor Stamberger, so if you do a mastoid, so maybe after 3 months, if you don't have discharge, you call it a stabilized cavity. But do you have something like that? Can you tell me when a FESS cavity can stabilize? I'm sure Professor Keerthane sir would have seen any number of cases. After 5 years, patient has had a beautiful looking cavity. After 5 years, he comes back with a polyp. So you never know when a cavity is going to get stabilized. So what is the definition of a stabilized cavity? So there is no, if you go and search on the net, there is no proper definition of a stabilized cavity. So this is something very, so now let us go on to see some examples. Yeah, just press, I just do that. Okay, now you see, when I see this post-op, so this will be a beautiful full house FESS, like, do everything there, that's the optic, skull base. The stage 1 looks like this. So what do you do in the stage 1? So in FESS, when you place a pack or something like that, do as less as possible in stage 1. So what is the duration of that stage 1? It lasts around a week. So the first week, do as less as possible. So, but during that period, try to remove just that amount of blood clots or crusts or something like that. So just remove that, but do not induce more bleeding. If you induce more bleeding, it's going to form a cycle. It's going to form again soft exudates. So if you find the second stage, you have soft exudates, you necessarily have to remove all these soft exudates. And if you find, this is the stage where you'll find all the stalactites. I was telling you about stalactites and stalagmites. So these are culprits because they are the exposed bone, raw bone. And if you have raw bone, believe me, you will have biofilm formation. So that is going to form a difficult situation for you later. And this is going to be the stage 3 where you have synechiae. If you have synechiae, you try to release it. Of course, the stage of stabilization and consolidation. And that's how a cavity should actually look like, but it doesn't look like that. Come on, carry on. So it goes like this. Okay, now this is stage 2. That is from the second week till the 4th week, you look like this. So what do you do? Can you just, So this is actually by Professor Sethi. He taught me this. So when you look at a cavity like this, come on, click. Okay, just stop it. Now, you see here, I've done an axillary flap, of course, for this patient. And what you do is all this, some people, brand this as recurrence. It is not recurrence. Actually, there's histamine inside. So what he says is just gently tap this. Just gently tap this polyp out. You're going to see what we do later. But you just gently press this out, and then you will have some yellowish fluid coming out. Yellowish fluid coming out. You just have to do that alone. Don't do anything more. Don't induce bleeding and things like that. So you just have to just gently tap it, and you see how it's going to heal now. That's a sphenoid sinus, of course, but you have this finding in some of your cases. That's a sphenoid sinus seen very clearly in your picture. Now, let us see how it heals. That is the way it's going to heal now after some time. So that's the healing process. You always have this teardrop appearance. If you have that's actually a very common finding after a very big middle meatal antrostomy. You have what is called a teardrop appearance. Okay, carry on with. Now let us see. Now this is a stage where you have the, just press it. Okay, you have the soft exudates here, and then how do you prevent a synechiae? See, that's a synechiae which is formed. So what happens is that I have not sucked the cavity of the soft exudates, and so what happens is that leads to a synechiae formation. I wouldn't allow this synechiae to form. It's not good for us to have a synechiae like that. So basically, you try to take off the soft exudates, do as less as possible, and try to take off just that histamine alone, and then you have a beautiful looking cavity. Next slide. Just carry on now. Now see, this is exactly what I was talking about also. And this synechiae, this is the stage 4, stage 3 of that is around 6 weeks. It starts from 6 weeks to around 4 months or so. You will have the synechiae formation. I try to release this synechiae, minor and major synechiae, and then what happens is that you have a cavity. Just play that, please. Just play that. Yeah, you see that synechiae. How do we release it? You have an office visit procedure every week. So what is my follow-up protocol? First, every week for 3 months. Every month for minimum 6 times he has to visit, and then every 3 months for 3 years, and then every year lifelong. So this is what I give it in writing. I just take that out. I take the synechiae out just as an office visit, and I don't want that synechiae to form. Why? Why don't I want that? Because this middle turbinate will be pulled by that synechiae. If you look at it on long-term basis, the middle turbinate is pulled slowly. Because see, never try, if you see all my surgeries, never try to push the middle turbinate medially too much. Very gentle pressure, as we saw, will be the best. If you try to massively push, there is a microfracture happening on the sagittal portion of the middle turbinate. And that, see, imagine you have a microfracture here. Don't you splint it? We splint a fracture of the middle turbinate only for 48 hours. We take off the pack. But what happens to this fracture is that it goes in for a malunion. Slowly, if you look at the turbinate, I've seen in several patients, I pushed it, slowly in a period of 3 to 6 months, it completely lateralizes. The long term, if you follow up these patients, the middle meatus is completely blocked. Next slide. I just want to share with you some of the experiences which I heard from. So this is an ideally looking per-operative cavity, but then this is the culprit. This is going to be your challenge in your post-operative period. So what happens with this? Okay, so this is a biofilm. Now, can you, so if you expose raw bone, what happens is that it's like a plague. The bacteria, it accumulates, and various kinds of bacteria come inside. It's not a single bacteria. Various kinds of bacteria come inside, and they involve different kinds. They work together, and then you see what happens. They form a matrix, and once they form a matrix, next slide. Press. Okay. Now you see they form thin pili. They form thin pili, and then they form exudates over it, which are very tough for the antibiotics to penetrate. So what happens is, this is going to be a big issue when you are going to deal with, see how they form the polysaccharide chains, the nuclei, it just forms a matrix, and that is going to, this is the problem. If you look at, I showed Dr. Ashish, if you see, I saw at least 3 cases here. If you see the frontal recess, you have real neoosteogenesis. Okay, I do a very good frontal. I go back, 100% this fellow is going to have a frontal sinusitis again. Why? That neoosteogenesis is actually a manifestation of a biofilm. So that is going to, you read your scans for thick bones. I showed you today in one maxillary sinus, just above it, there was a thick bone. I showed you and dissected that out. If you had left that, believe me, that patient is going to have sinusitis again. So these are the things which you have to read. Thick bones in any operated cavities, try to take it out. So they are manifestations of plaques or biofilms. So these are new osteogenic material. So how do you treat it? So now what we have started doing is using honey. So honey as a douching material, it's fantastic. And this is what Professor Ormold has done a lot of research on. You can find articles on that. So Professor, your experience on this, do you douche patients with honey? But this is.
I've never used it, or I've been reading about it.
But it's brilliant. It's really brilliant. I think what now we do is we mix saline and then we use mu pyrosin. So mu pyrosin, you can ask Karao. He has done a lot of work on that. We mix mu pyrosin with saline with a little bit of honey. Of course, the concentration they say is MgO concentration greater than 0.53, and that actually causes low pH, high osmolarity, hydrogen peroxide generation. So high methyl glyoxal is how it acts. So this is the treatment for biofilms. There is no proper treatment. You cannot give, and believe me, don't give azithromycin. That's one antibiotic you should never give postoperatively, and that has been under studies, a lot of studies. Now I'm going to give you a 5-prong attack. It's called the 5-step program after treatment of your very good super FESS. You do a super FESS and then you leave it like that, he's maybe going to come back. So what are you going to follow up him with? I mean, how are you going to follow him up? You can use baby shampoo. You can use 1% baby shampoo. It's very good. You can go onto the net and see the trials. We have done it. So number 2, use nasal douching as I told you. Use my mu pyrosin with a little bit of honey with steroids. Fantastic again. Number 3, in all skull-based cases, we use my mu pyrosin with saline. In all skull-based cases. And it's fantastic for crusting. We use antibiotic mu pyrosin and we use pulse irrigators. So there are actually studies regarding how to irrigate and the frequency of irrigations. So that I'm not going to in detail, maybe so maybe Satish can elaborate on all that pulse irrigators things. So this is what I always say, the 5-prong attack after your FESS should be this for you to avoid recurrence. So if you do this, at least for revision cases, I think you will be better off in your results. So thank you very much. I think I kept on to 20 minutes. Thanks.
Thanks. Sir, Satish, please come. No, there's no more. Do you line in a
Sit here, I'm going to sit here.